ACDF is a very successful surgery, right, Dr. Shen?
Very successful, yeah.
So why would you make the shift to a different technology?
ACDFs, when you look at the literature, great results. 90% patient satisfaction, morbidity, everything, great results. Problem with it was adjacent level disease. It was restrictions in motion. It was longer recovery and rehab. So from an orthopedic standpoint and orthopedic background, it was always about patient function, range of motion, restoration of activity. And in the very beginning, it was not available in the spine. But when you look at artificial disc and what it can do, superiority, it's not equivalent, it's superiority to fusion in terms of results and patient outcome. Quicker recovery, quicker rehab, things like that. Adjacent level disease, protecting the adjacent levels. How could you not embrace a technology that could give that to your patients?
And was it something kind of over time that you worked more into your armament of treatment options?
Yes. In the very beginning, always interested in motion preservation technology, but in the very beginning, the indications were very limited, just in terms of what the FDA found and what their indications were and your patient population. And one level, those patients were, harder to isolate because patients were coming in with two-level disease or different degenerative processes going on. So over time, as the indications and the research and everything came out, it slowly became, rather than fuse everybody and find that artificial disc patient, to artificial disc everybody and find a reason why you have to fuse. So the thought process, not only in the literature, but also in my own practice, that's kind of the change that you've seen over time.
Yeah. So, Michelle, it's been about a year since your...
Yep, I'm a year post-op, exactly.
And what were your symptoms before your treatment?
I was having migraines 3 to 4 days, the last 3 to 4 days, my left arm. I'm left-hand dominant. I was having all kinds of pain shooting down my left hand. My grip was losing. I couldn't grip hardly anything. It was really weak. My right hand was stronger. I never ever used my right hand, ever. I could be without it and be fine. But my left hand, it was painful, everything. So I was tired of taking drugs, tired of having migraines all the time. I got a referral to Dr. Sheen. He said I was a perfect candidate. I said, let's do it, and we did it.
Were there things that you were missing out on?
I was missing out on my son's baseball games because of a migraine, because I had to pop too many pain pills to get it under control. Family picnics, family camping trips, all kinds of stuff. It was just way too hard, popping pills all the time. They just want to give you pills, that's the answer. I wanted my life back. I wanted to be able to function. I wanted to live again. And thanks to Dr. Sheen and this disc, I can move my head any which way. And there's no pain, no more problems, nothing down my arm. My strength is back. It's amazing. It truly is amazing.
So, yeah.
Isn't today your 1-year anniversary?
The 20th.
Okay.
Last week.
Yeah.
Yep.
Yeah.
Oh, wow.
One.
And Joseph, you're 3 to 4 weeks out?
3 or 4 weeks out. I went back to work the next day. So I did bug Dr. Sheen about that. Please let me go back to work as long as I'm not lifting. He let me do that. So I'm very grateful for that. But I had not the same problems. I did not have migraines, but I couldn't, basically I was dropping things. It got worse for the past 2 or 3 months prior to this, where it was affecting my job. And basically, it's hard getting out of bed, period. Constant pain right down through here, right down through here, but all the way down to my hand, my left hand. Just severe pain. And the instant I came out of surgery, I felt the relief right there and then. I have no pain in my upper back right now at all. I feel great in my upper back.
So in prior to the surgery, you probably had some time to investigate what your treatment was going to be. Where did you look to for additional information?
Well, she was my information.
I was the
This is
guinea
my
pig.
this is my better half, believe it or not. So, I wasn't nervous at all. So
I was scared.
Yep, she was scared. I wasn't. So, but we did spend a lot of time for 2 or 3 weeks debating on, Dr. Shen letting us do this. But again, knowing Michelle, I've known Michelle for 12 years. She had a tumor about 10 years ago, and she was terrified to get cut on her stomach, and then of course downstairs, and she was freaking out at here for 2 or 3 weeks. She had to get it done, but because she was in so much pain, she wasn't worried at all. So I knew that something was wrong. She wasn't bluffing. This was pretty serious. So to get a cut on her neck, and which you can barely even see, and where mine, as you see,
tell,
you
could
can
you?
see. So.
Can't even see it.
No, you really can't. And so, Joseph, you alluded to post-surgery, alleviation of symptoms and back to work. Michelle, was it a similar situation?
I couldn't go back to work because I work in the dental field. So I bending and moving, lifting, all kinds of positions. So I had to wait a little bit before I could go back to work. So I did have to wait, and I did my physical therapy, and it was great. The waiting was hard, but it was fine. It was really hard. I fought with my physical therapist. I'm like, just let me do it. He says, no. But because I was ready, because I felt so good. Like, it's completely different. It's so amazing how you feel. You're going from hurting all the time just to feeling so good, you just want to go. But you can't. You do have to go by the guidelines in order for it to work properly. And, make sure you follow the doctor's rules, not what you're supposed to do. And it was hard, but I did it. And I am thankful that I did, because it was the best thing.
So are you able to return back to the activities
Yep.
that you were missing before?
Absolutely. My son is not playing baseball right now because they don't have tryouts yet, but I will be going to his games.
She bowls.
And I do bowl now. I'm not very good at it, but I bowl again. And I do all the stuff before. We went camping. I go to Sturgis every year. I did Sturgis finally again. It's great.
Fantastic.
Yeah.
And Joseph, you have a few limitations coming right off the heels of the surgery?
Mm-hmm. Can't lift anything.
Okay. But the pain is gone.
Pain is gone.
You should have seen as soon as Dr. Sheen was then in the hospital room, he's like jumping up saying, I feel great. The nurses are all getting him to sit down, sit down. He was like ready to go.
Dr. Shen, is there anything specific to Mobi-C that you particularly like?
When you look at the biomechanics of it, I think it's superior to anything else. The 6 degrees of motion and the axis of rotation, everything's always moving. It isn't just one fixed point. Otherwise, it would just be like a rod. So the mechanics of it most represent normal cervical motion. The fact that you aren't cutting keels into bone, and the fact that you aren't worrying about fracture when you do adjacent levels, it's everything about it. And the delivery system has been streamlined to such a point that it makes the delivery and the equipment with it just so much easier.
Mm-hmm. Mm-hmm. And you mentioned in some of the other breakouts that the differences between ACDF and disc placement are substantial.
They are. So a fusion's actually not that hard a procedure to do. Doesn't matter how collapsed you have, doesn't matter posture, position, anything like that. You can contour bone the way you want it to be. But the artificial disc, preservation of your soft tissues, preservation of balance, releases that you do, placement of the implant, preservation of your end plates. There's so much more about an artificial disc that's technical compared to a fusion. Yeah.
On that, I have a question.
Yeah.
You talked about it's a little bit more intricate doing the artificial disc compared to the fusion.
Sure.
What would you say to some of our surgeons that try Mobi-C once and then never try it again? How would you encourage them to start using it or to perfect it?
The biggest thing is, the biggest reason for perfecting your skill and making that part of your armamentarium is if you do a fusion, sure, that's something that you're comfortable with, but you're in it for your patient, okay? That's why you're doing what you're doing. So if you're not comfortable, if there's something that you don't like or you want to change, you know, the engineering guys, the product guys are great. And you want to do a superior surgery to give your patient superior outcome. You know, you just don't want to do an easier procedure and then have them feel good, but then next thing you know, the fusion doesn't take, or their adjacent levels go, or, you know, you're in it to help your patient. And so if you do have some, get trained again, go to see other proctors. The reason why we're doctors is because we're here to help them, not just do what we're comfortable with. Not everything's a nail when you're a hammer, so.
And what made Michelle and Joseph good candidates for OBC?
So, like I said, in the very beginning, when the indications for artificial disc were minimal, it was hard to kind of isolate that patient. But for them, it was, concordant with their injection reports. It was their MRI, it was their bone stock, it was their age, it was their activity, it was their health status. It was kind of what they wanted to do after surgery, get active again, okay? All those things made them perfect candidates.
And do you have confidence that this disc is going to last for a while?
Biomechanically, it's supposed to last a lifetime. I was corrected last group. I 5 million cycles, then suddenly out of the group I heard, no, 10 million cycles. I'm like, well, that's a lifetime, okay? And so, yeah, it's supposed to last a lifetime.
What do you mean by cycle?
So, when you look at bend, twist, turn, and things like that, you actually have to show over time through your biomechanical research what's the wear and tear going to be like on your prosthesis over, literally putting on a machine and moving it for 1 million cycles, 2 million cycles. The Mobi-C is tested to 10 million cycles, okay? And that's where you're looking at, okay, how much wear, how much, what's going on with the prosthesis? Is something going to change over time? Because we know with artificial knees and hips, once you put them in, you start the stopwatch, it's going to wear out. You're going to be back. Okay, but with artificial disc replacement, 10 million cycles, that in itself, biomechanically, is meant to last a lifetime.
Good question in the back.
Dr. Shen, you are still the minority in terms of how you think about this. I understand fusion is by far the more prevalent procedure. Why is that? What needs to happen?
Surgeons are stubborn to change, I think. Once we kind of get stuck in our corner and once we like to do what we like to do, I can do a fusion, I have great results, things like that. That's the one thing. Second thing is the indications. So, before, up until recently, it was one level only. Okay, well, how many of your cervical patients are one level only? Not as many as your 2 levels and then 3 levels and things like that. So as indications broaden, as the literature comes in, before, it was kind of early 20s to mid 40s. And then as you look at the literature and how patients are doing now, it's kind of into the early 50s. And then now it's, okay, maybe even early 60s. Okay, looking at their bone stock and things like that, making sure you don't see any deficiencies there, looking at their levels of degeneration. I think sooner or later you are going to see this switch. For me, the switch happened a lot quicker, I think just because of the orthopedic background in terms of range of motion and mechanics and things like that, something that I was much more interested in. And in terms of, just looking at the literature and showing superiority to it, how can you not listen to that?
I would think as patients find out about it more and demand that more and go to surgeons who do it, that might help other surgeons.
Yeah, absolutely, absolutely.
I
So,
don't want that.
sure,
I wanna go to
absolutely.
surgeons.
So, over time, the patient population is becoming much more savvy. They will come to you and they'll say, well, do you do this or do you do that? What do you think about this? I haven't tried that. So, patients are coming in much more educated, and that definitely will help things as well. Absolutely. For me, the better I can educate my patient, the better it is for not only me, but for them too, okay? Because, you know, you go into surgery and you have all this worry and you have all this intimidation and everything like that, but if they understand what's going on and you have that better rapport with them, you know, it's better for the patient.
What do you think about a patient coming in and saying, I want this Mobi-C?
First of all, you know, you have to make sure they're a candidate. Okay, so if you're looking at their studies, what they've been through and things like that, you know, you have patients that will come in and say, you know, I want surgery, and they're like, well, you know, have you tried therapy? Have you had injections? Have you tried anything else? Things like that. You know, for me, I'm a very conservative surgeon. You know, the reason why they had their surgeries was because they tried everything. Nothing worked. So then you try. Then you know, my job as a surgeon is not to operate. That's not my job. You know, my job is to make you better. That's it. Whether or not it's conservative or operative. And so if you have these patients coming in, I read about this, I want this. Okay, one step at a time. Let's just see where you are, and then we'll go from there. Okay.
Do we have any other questions? Where do you see the future of, you know, cervical disc or even disc therapy in general?
Definitely expanded indications. So like I said, the patient population is just expanding in terms of, you know, before it was kind of this window, and then it's this window and this one. So the age groups are expanding. The levels are expanding. First it was one level, then 2 years ago it became 2 levels. And so is that going to expand even further? The use in more active patients. So, you know, the use of, you know, fusion technology in individuals involved in contact sports, okay, heavyweight training, UFC, things like that, you know. I think we're going to start to see use of artificial disc in that type of population. Hybrid techniques, so, you know, do you always have to, you know, now if you're getting into 3 levels, can you maybe fuse one level and do artificial discs in another? Adjacent level disease, so, you know, I had a fusion before this technology came out. My adjacent levels have gone. Can I do this instead of marching up my fusion? You know, there are a lot of indications that I think that are going to expand the indications for this type of technology.
Mm-hmm. Yeah, and many of those that he mentioned are off-label, and we would need to pursue that indication. Any more questions? Yeah.
Surgeons who aren't comfortable using Mobi-C refer to folks like you, their patients, because they agree that it's a superior.
No, unfortunately not.
Universally recognized as superior, but more and more folks are starting to.
Yeah. Well, you know, because the whole thing is when you look at the literature, you know, the thing with new technology, the burden that you guys have is, you know, don't show me equivocal. Okay, so you're going to give me an implant or this technology that's equivocal. Well, then why are we even doing it? Okay, give me something better. Give me something superior, not only in terms of, you know, restoration of or retention of motion, but adjacent levels and patient function and patient return to all these things. Show me superiority, and that's what the burden of proof has been done. That's what the literature shows. And so, you know, getting back to that, unfortunately, you know, you have some surgeons that, you know, don't want to learn or don't want to train or try it and are uncomfortable, you know. Get back in there again, you know. This is a good product. This is a good technology.
So you're operating in certain hospitals?
Yes.
And there's other surgeons operating in the same hospitals who
Mm-hmm.
don't do Mobi-C.
Mm-hmm.
Do they come and watch?
No, it's kind of your OR, my OR kind of thing. But, you know, the benefit of this is, you know, 1 level, 2 level artificial disc, you know, we didn't even do it in a hospital. We did it in a surgery center. They went home the same day. You know, that's how quick it's really become.
So, Joseph and Michelle, when you're talking to friends and family about the whole experience in general, you know, what is the story you tell?
They can definitely see a difference. They say that it's nice that you're actually here participating because I can now
And on time.
and on time. Not all looped up on drugs. I'm actually not slurring my words. I'm actually talking, participating, and just movement. They could totally see a night and day difference. Like, oh, look, you can move your head all over and you're not like cringing or in pain, or they could totally see a big difference.
Yeah.
It is the best thing. It's like, I don't even know how to describe it. It totally is really night and day from where you were to where you are now. And I am, like I said, I'm a year post-op, and you can't see my scar. It's gone. I can move all over. I can do anything I want to do. Anything. I'm normal again.
How many days would have he missed work if he would have had a fusion? He went back the next day. On average, what would you say he would have missed?
Minimum, at least several weeks.
So this is
Minimum.
like a great solution for insurance companies even to save a lot of money.
We'll get your scar there, Joe. 3 or 4 weeks, you gotta give us some time.
Mine looks good.
Yeah, the worst confidence was when I came home and says, yeah, your scar looks like shit. Like, thanks.
Give me some time, we'll get you there.
Well, I want to thank everyone, and especially I thank our panel for all 3 breakouts that we had today. It's been a fun day. The time has gone super fast, and yeah. So can we just give them a round of applause?